morning, good evening, good afternoon, depending on where you are on this beautiful planet. It's Paula Nutting here, your musculoskeletal specialist, and today's Ask Me Anything. I've gone back over to the UK again and have the opportunity to talk to someone who has been involved in more the rehab kind of side of things. We're looking at kinesiology or kinesiotaping, exercise physiology, rock tape, things to get our clients and our patients, not so much maybe as much hands-on during the clinic, but some awesome things to do when they have left the clinic. So without further ado, I'm going to get Daniel Lawrence, who is going to come on board with me for the hour. Hey, Dan, join us when you can.
Hi, Paula. Thank you very much for inviting me. I'm looking forward to having a chat. Thank you very much.
Excellent. So a couple of housekeeping things, two things. One, Libby Jones O'Flaherty, she's Ireland, so she's one of the people who actually know how to get onto StreamYard. If you are new to the streaming service that we've got going on here, it's not, new to the Ask Me Anythings, it's about ask me anything. Like the verb here is ask. So if you want to be able to have questions answered from Dan or myself, but mainly Dan, please type them in the text box. We'll address them as we can. So be vocal, ask loads of things, because we can answer them in the next between 45 and 60 minutes. Sometimes we get a little bit long, as Libby knows. We can have some crazy stuff, aka John Sharkey, who doesn't know how to stop a conversation. Secondly, I just want to do a quick plug to Q Academy and all of the staff, the campuses, the online training, the face-to-face courses, and the combinations of online and face-to-face component. Q Academy is a Queensland-based education facility. It focuses on what used to be Cert 4s. Now they've kind of been embellished into the diplomas, and our advanced diploma of myotherapy. So if you're interested in changing your career path from something that you have been doing to something that you probably think that you would like to learn a bit more on, so you might be listening here as a Pilates instructor or a yoga teacher, or someone who's done their spa training and you want more information, go to these guys. They do accelerated learning techniques. Every moment of your educational experience will be fun and full of laughter, because we all know that's how we learn and absorb best. So contact Q Academy for all your education needs in this environment. So there's the plug. Back to Dan. Dan, please, I don't know much about you, aside from the fact that when I was talking to Emma Holly last month, she said, you have got to contact Daniel because he is the duck's guts. So give us the Daniel Lawrence story.
Well, on the one hand, I'm thankful to Emma Holly for putting me forward, but it sounds like she may have put me on a high pedestal. But it's very kind. So yes, well, I'm a UK-based physiotherapist. This year I would have been qualified for 20 years, which is an interesting amount of time, because you can do a lot of reflection on the past 20 years and things you've seen and things that you are experiencing and witnessing in the profession and the therapeutic industries at large, and the changes that are coming through. And sometimes you see things, coming round again, but with different names and different labels. And I always remember my senior colleagues saying to me, "Oh, we've seen this before. This, just a different name and a different, different marketing, etc." And I'm witnessing that myself as well. I think there's always changes in healthcare, more specifically in musculoskeletal healthcare, and I think it's always interesting to see those changes come in and discuss them, and talk them through with other professionals such as yourself, because the range of opinions are always very interesting.
Sure are. Tell me, because there's Australian physiotherapists have a different mindset to the massage industry than, from what I gather, America. And I'm going to ask you, what is it like with the UK? They look at a lot of the stuff that we do, as in hands-on soft tissue manipulation, whatever you want to call it, like touch, as having no credibility because there's no research that says that it actually works. Is that the same as the UK?
Yeah, that's very interesting. You mentioned the Australia and America and the UK there. And I think there's definitely significant differences with the way that a physiotherapist or physical therapist in America would work. And I think, as you've already highlighted, it's a kind of professional and cultural thing. But I think it's also due to the way that healthcare is funded differently in those three countries, perhaps the UK and Australia being more closely aligned, and America having much more of a private healthcare model. Many of my colleagues through my work with Rock Tape are in America, so I've heard a lot about the way the American healthcare system works. So there's key differences. Like even within the countries though, so here within the UK, for a long time there has been a camp of exercise rehabilitators and a camp of, say, manual therapists, perhaps including massage therapists, but also physiotherapists and osteopaths and chiropractors, for example. So there's often been sometimes an unnecessary divide between manual therapy versus exercise rehabilitation. And I think social media has certainly strengthened that and perpetuated that divide. But it's always an interesting debate. So if there's anything in particular you wanted to discuss within that, then that would be perhaps an interesting place to start.
Hey guys, it's Paula Nutting, your musculoskeletal specialist, and this is that awkward, cheesy kind of part of the video where I ask you a big favor. So if you want great content and lots of information, you can see down here in the little testimonials, there's free manual therapy information. There's really cool stuff on necks, shoulders, backs, hips, wrists, arms, etc., etc. I've got amazing Ask Me Anything podcasts and vodcasts that you can get free access to. If you want to get that great content, can I please ask you three things? One, can you please subscribe to my channel? Two, can you hit the like button? And as they say, just smash the heck out of that like button. The more information that YouTube gets to me, the more I can give content to you. And if you can click on the bell, that will also give you timelines for when I'm actually dropping something into YouTube so that you can access it really quickly. So subscribe, like, and click on the bell, and I'm hoping to get you as much great content as I possibly can. Paula Nutting, your musculoskeletal specialist.
I find that it's, just from my experience, looking at places like the Fascial Hub, which is the UK, the amount of research that they're dropping into there, and fantastic speakers, especially in the area of myofascia and the fascial systems, and moving from there to fluid. So how's the lymph, and what's going on from there. So it's starting to get hard research with ultrasounds, on real-time ultrasounds on a technique versus how the fascia was before and after, the hyaluronan, mobility, flexibility. But when we start mixing, how does fluid affect, or how does lymph affect fascia, and we're putting two systems in, then we lose the research model again.
Yes, I find fascia fascinating. I've been involved with the sort of fascial movement here in the UK. I had the honour of speaking at a UK fascial conference a few years ago, and I was on the stage before or just after Robert Schleip, which was fantastic. He's a very fascinating guy and a great speaker, and also my work with rock tape has involved a good understanding of fascia as well. And you mentioned the different systems there, which is really interesting, Paula, because I think that one of the issues that I've seen over the last 20 years is people get too wedded and embedded in different systems, and think that all of the issues with an individual's health are to do with a particular system. And sometimes that's because there's certain research is popular at the time, or there's a move to talk more about particular systems like the fascial system, the neurological system. I think at the moment we're becoming much more aware of, say, psychology and behavior change, which I think is very, very interesting. So there are definitely popular themes within understanding and within the research. I always remember meeting a particular lady at the fascial conference who said that she only treats fascia, nothing else. Yeah, I'm glad that landed well with you, because to me it just seemed a bit bizarre, because when you treat somebody, you know, whether you know it or not, you're treating all of the systems. Even if you do not speak to the person, you're still changing their psychology and probably bringing about some behavioral change, even if you do not have a conversation with them. Just the very fact they're spending time with you in a therapeutic sense is going to have an element of psychology, not to mention, you know, neurology and the changes to cellular metabolism and all of these things which occur with either hands-on therapy, massage, or exercise therapy. I really don't think we need hard lines between those two things.
I'm so glad to hear that, because I think that's the model that we need to be looking at is person-centered approaches, and whatever that's going to look like to the benefit of that individual. Because you can be two people come in with the same shoulder pathology, the same symptoms, the same injury, like the ultrasound's the same, blah, blah, blah. You can do the same technique on both people and have different outcomes. So exactly the same. And how many times do we hear?
Just to expand on that, sorry, I was thinking about something else that I wanted to mention. I have a habit of drifting off. It's not the Wi-Fi, it's my brain. So where were we? Yes, you were saying that you can do the same treatment and get different outcomes, but and absolutely, I'd also say that you can do different treatments and get the same outcome, because I think you and I probably meet a lot of other therapists through our educational work, and I'm quite certain that I could meet many people that treat in different ways, maybe from different professions, and they still all have happy patients that are pleased with the results and they're helping people, but they're all doing different things. So perhaps the question is, what's the key ingredient which is providing the good outcomes? And I have an idea what that might be, but be interested to know what you think.
Well, I how many times do you hear someone who books in to see you, and then when they arrive, they go, "It's been terrible, and I woke up this morning, and I knew I was coming to see you, and it's gone." You know, well, there's your placebo. And placebo is not a dirty word. You talked to Whitney Lowe, and we had a big conversation on pain, and there Libby's going, the biopsychosocial model, and that's it's how we ultimately start our own healing journey when we go, I feel confident, I'm going to see Daniel. What's the first thing that happens? We drop our inflammatory markers, our stress levels drop down, we start producing the serotonins and all the things that are actually going to help our own healing process before we've actually come into your room. And then trust. So there's, for me, I think that the more you can get rid of inflammation, the greater opportunity you'll ever have to get better outcomes.
Yes, yeah, very much so. I'm very much aligned with what you said there. So I'm just wondering what I can add to that. And I think possibly, I mean, firstly, it's very hard to separate the placebo from any active component of treatment. Research always tries to do that, but it's very, very difficult to do that. The surgical research is fascinating, where they use sham surgery, pretend fake surgery, so that the individual goes through the surgical procedure and maybe even has an investigative procedure, so they still, anesthetized and have a scar to show and so on. And when they compare the two groups that actually had a surgical intervention and the group that just had a surgical exploration, so no intervention, then the two groups in many cases in the musculoskeletal world have the same outcomes. And I think that research is very powerful, because therefore surgery is the biggest placebo. And there's a fascinating book that I read. You've probably seen it. I think it's by Ian Harris, and it's about surgery and the placebo effect. And it talks about and presents the research there, which is fascinating.
And let's not talk about the ethical ramifications of that.
Yeah.
Right?
Yeah, of course.
And this is off point as well, but again, it's that I've got back pain, therefore I must have a problem with weight. Like, I've got disc problem, I've got degeneration, it's back pain, I'll never get better. They had, I was listening to something on this topic last night, because I have no life, and probably nor do you, Daniel. So I'm watching this thing, and there was a study that took 100 people with no back pain, healthy, from the age of 80 onwards, and they did MRIs on all of them, and over 90% had either spurs, significant degeneration, and or discal compromise. So
yeah, that's fascinating. Yeah.
Yeah.
I wonder then if I can mention my YouTube work here, because
Absolutely.
that ties into what you've just said. So my YouTube channel is called the Physio Channel, and there's videos on there for professionals and for patients. And I wanted to mention a couple of things. Firstly, the placebo effect, because if I was ever to persuade people to start a YouTube channel as a health practitioner, so to be a health creator, I would highly recommend it, because one thing that it does is it allows people to get to know you, it builds trust, and it's a very easy way for people to make contact with you, without your actual live involvement, so that they can start to understand how you work and be confident in contacting you and speaking to you. Because word of mouth, of course, is very big in our profession, but sometimes people want to do some research and see, where is Paula based, and what does she treat, and are there some Google reviews? But if they can go on to watch some of these podcasts, for example, then they can listen to you, and they can get to know you, and they can feel more confident. So I made a video on bicep tendinopathy, and many people have watched it, but I had one chap contact me and travel a few hours to come and see me, which is quite rare in the first case. But when he got here to see me, he knew me. Oh, hello, Daniel. Nice to see you. And he was already very, very confident and very pleased, and he knew me because he'd spent time watching at least this particular video and possibly some other videos. And it was quite strange, because normally, in a positive way, by the way, normally when we meet a patient for the first time, we're the ones that are confident, because we know what we're doing, we know why they're there, it's our clinic and it's comfortable. But they're usually nervous because they haven't met us before, they're not sure what to expect. and they're the ones that are sort of, you know, a little bit uncomfortable, and we need to break the ice and build rapport. But this was almost the other way around. He knew me, but I didn't know him, which was bizarre. But then that links into the placebo effect, because he'd already been to see lots of people I consider to be quite specialists and experts in the area, in the shoulder area. And I did say to him before he came, you know, you've seen some really good people, and I'm not sure if I can help, but if I can, then I'll probably be looking at this and trying this and doing this. Mm-hmm. So he still came to see me, despite the fact that I said, I'm not sure if I can help you because you've already seen some brilliant people. And he still wanted to come and see me based on his time watching the video, and he was very confident in my ability. And that, I'm pretty sure that was a very powerful placebo effect. And he came to see me with high expectations. And I think one way of describing the placebo is a positive outcome expectation.
Yeah.
And if ever your patients can have a positive outcome expectation, then I think that's a very powerful part of the placebo effect, as is the relationship with the practitioner. I believe that of all the different things that we might do and that different professionals might do, the reason that we might be arriving at the same result of you know, a happy and a satisfied recovering patient is probably the empathy and the relationship with the patient. If that's strong, then I think there's a whole range of different things you could do to potentially arrive at the same result. And I made a video recently on just what you were talking about there, which is the misunderstanding and the misnomer of a slipped disc, and the fact that is not a thing, but of course people still think it is. And it is a problem, because if you think you've got a physical slipped thing in your spine, then it's going to make your pain worse and you're going to move less. And I looked in the video at some research, and it was very similar to what you mentioned about disc bulges being common, especially in the latter decades of life, and often not being related to back pain. So you can have many people with a disc bulge that don't have symptoms, they're asymptomatic. So although a disc bulge could be a cause of pain, it's a rather unreliable marker of the problem.
Yeah. Yes, I agree. But it is quite easy to actually, well, it's not quite easy, but you can always do specific orthopedic tests to wind that bad boy up and upset it to create the symptom picture, which we probably don't really like to do, nor do we like to do surgery without actually doing anything and thinking that that's ethically fine.
Yeah, absolutely. Wind that bad boy and upset it. That sounds like an Australian originated test.
Yes.
What sort of test would you do there, out of interest? Just
well, all the like the Valsalva, automatically to see if there's any compression in there, anything that's going to increase your intra-abdominal. Like you can do all your straight leg and all of that, the whole neural, but it still doesn't really capture, like it's capturing nerves. It's not necessarily capturing disc. One of the big things I normally say to my patients who I see, and I don't do a lot of, like, I don't do hospital where I sit in my industry. I've got a degree in health science, musculoskeletal. So I'm kind of like getting a massage therapist, an osteopath, and a physio, and putting them all together. That's kind of what my 3-year learning educational pathway took for me. So I'm not at that acute stage. There's I'm trying to think where I was going with this. Where was I going? I was on a rant then. It's very
sorry. I think I talked for too long and probably threw you off.
No,
we were talking about discs, and I just asked you about the tests, and we talked about placebo.
When we were here, like when we went through our degree, we'd be doing tests, say the McMurray's, at Lachlan's, and checking, say, knee pathologies. And they said, really go hard on those orthopedic tests, because when the surgeons do it, they actually do it to see if they can snap. So then they just go, right, we've snapped that, we've torn that ligament, or it was disrupted it and it's avulsed or whatever. So we are going to do the surgery. It's not like this gentle, are we getting a touch of that so let's back off? I don't actually do the hard, rapid moves because I just think that like there's patient care, and then they don't come to see you because you've created a nocebo, and that's the last thing that we need.
Yes.
Look, I'm gonna throw down to find out some stuff about your YouTube channel, because I'm seeing the physio channel coming through here. But talk to me, because your main passion, I think it looks like it's kinesiotaping. Is that like?
That's yes. I have many passions in physiotherapy, and I'm always, probably like yourself, always learning and want to explore new areas. So I'm trying to learn yoga at the moment, but we can't talk too much about that because my efforts have not been too impressive. But prior to that, some Pilates and before that, various other things, including topics around the books that I've published over the years.
Oh, you've published as well in rock tape.
So yes, my first book. So I will get to the question about taping, but my first book was on tendinopathy, lower limb tendinopathy, the 4 main lower limb tendinopathies, and then expanded it to 7 with an online course. So tendinopathy was perhaps my first passion. And then I published a book on the modern use of clinical cupping, which sits alongside a course that I teach, which links to my work with rock tape, because we have a product called rock pods, which are myofascial decompression cups. And then a book on exercise for pain relief, which is an exploration of how exercise reduces pain, the different mechanisms, and what to do when it doesn't work, because exercise rehabilitation for pain relief doesn't work as well as we would like it to. So I looked at how it works, and why it might not work, and what can be done about it. So that was very much.
I'm going to jump into that one component there, because my thing is all about muscle firing sequences working to stabilize a joint, or stabilize a region. Do you find that, like, is that, for me, if an exercise doesn't work, it's because muscles that are not, like, the patient hasn't got the neurological pathway to create the exercise pattern that you want them to do?
Yes, there's many reasons, and that's certainly a key reason, absolutely, Paula. But I wonder about your question was, when exercise doesn't work, I would ask what we mean by that. Like, what do we mean by exercise doesn't work? I would perhaps suggest it doesn't work as in it's not reducing the pain, because that's often what patients would report is my knee still hurts, so therefore the exercise isn't working. And the fact that you've measured better muscle function might not be of any interest to them, because their knee still hurts. So even if they're stronger, they would be somewhat dissatisfied with the exercises if they were still in some discomfort. So yeah, I mean, in the book, it was fascinating to look into how exercise works, because I really don't think, and this is in rehabilitation, not in performance, I really don't think that exercises work by strengthening the joint, strengthening the muscles and supporting the joint. That's a very simplistic way of explaining it to patients, and they can understand that. But I think it works in many other ways, and one key way is descending inhibition, and those natural pain relieving chemicals being released by the brain off the back of doing exercise. So therefore, it's not about the specific exercise. Any form of exercise that increases the blood pressure in a way that stimulates that descending inhibition can lead to pain relief throughout the body, and particularly at a joint. But that doesn't always work, and we know for a long time, but it's sort of emerging now into more general knowledge, that the evidence base points towards exercise rehabilitation. So like the UK physios are perhaps known for, in the hospital setting, hands-off exercise rehabilitation is evidence-based. Yes, it's evidence-based, but as far as patients are concerned, it's still not good enough, and it often doesn't provide satisfactory outcomes. It's not the panacea that we thought it was. And I was looking at some research just yesterday to do with the reduction of knee pain. So is a good study. There's a group of patients and two groups. One group did exercise for their knee pain. The other group did not do exercise for their knee pain. And a passage of time went by, a number of weeks, and the non-exercise group had a 6% reduction in pain, probably just because of the passage of time. And the exercise group had a reduction of pain of 24%. So, like, if you think, brilliant, so doing the exercise, 24%, that's hugely improved compared to the 6%. So obviously you'd want to do the exercise. Now, they did that exercise for like quite a number of weeks. I can't quite recall, but let's say like 6 to 8 weeks. It was quite an extensive length of time. So we know what it's like for patients to do their exercises for 6 to 8 weeks. It's quite a commitment.
They're not compliant. None of us are.
No, but let's just say they did and they were diligent. They had a 24% reduction in pain. Would you be satisfied as a patient with only a 24% reduction in pain? That's not quite 25%.
5% of I'm not loving you right now. Why am I spending money? Why am I losing my time when I'm get me a better result?
It's hugely better than 6%. So from a research point of view, it's great. But if we talk about expectations again, if the patients have an expectation of being, I don't know, pain-free, and that's an issue in itself because that might not be a reasonable expectation, and they only get a 24% reduction, I think there's still a lot of dissatisfaction there. So what the research says versus the reality of patient expectations are often quite sort of very, very separate and challenging. Now, sorry, you asked about taping. So taping's
I'm wondering if that drops into there then. Like you increase it 24% because you're actually supporting.
Yes, so taping's been a big part of my career. I'm the education director for a company called Implus, but my focus within that is on the brand Rock Tape, and I've been involved with taping for all of my career, but particularly with Rock Tape for around 14 to 15 years. And it's been fascinating to see the emergence of kinesiology taping in the UK, and we have strong partners in Australia too, and America. It's been fascinating to see it evolve over the years in terms of its usage by a broader range of professionals, its usage on animals as well as humans, and the emergence of a huge body of research. It's probably one of the most well-researched musculoskeletal interventions out there.
I agree.
There's a huge amount of research to lean on, which is really interesting because although it's been around since the 1970s, it's really only been popular since the early 2000s in the West. And around that time, there wasn't that much proper research. And we often would get people come up to us at conferences and events and say, where's the research? And it would be like, almost accusatory, or you must present the research as well. There is some research emerging, and now nobody says that because there's a huge amount of research out there to lean on, to talk about, and to inform the use of the tape. Some people wonder what the difference is, by the way, between Rock Tape and Kinesio tape. So Rock Tape is a brand of kinesiology tape. It's well known for its quality and the fact that it sticks, because some tapes, the adhesion is not so good. Rock Tape started because a Californian entrepreneur, Greg Vandendries, he used Kinesio tape and he loved it, but found that it wasn't quite durable enough for his endurance sports, for cycling at the time. So he went to the company with a background in health tech and offered to work with them and improve the product. That never happened. That never went anywhere. perhaps even an email wasn't answered, I don't know. So he then started his own company where he made tape which was better for endurance athletes, because it was a bit tougher, a bit more elastic, and the glue was stronger. And then that was the birth of rock tape. But it's not used just in sport. It's often associated with that. But here in the UK, one of our most popular courses is for neurological physiotherapists who just work in hospital healthcare settings. And there's research for its use with post-stroke shoulder hemiplegia, Parkinson's disease,
really?
cerebral palsy. Yeah, there's great research around the use of the tape there. And
So
the sort of
if someone's had a left-sided stroke and they've got weakness on their right, are they talking about taping to support the, like, run me through that, Batman, because that sounds like
Yes.
really interesting, like really
yes,
interesting.
of course. So there's different ways of looking at or explaining or theorizing how taping can work, and the mechanism of action that's talked about most with taping for neurological conditions is its influence on the nervous system. So when you apply tape in the first instance, it stimulates the nervous system. It can boost proprioception. The brain becomes more aware of that area because you've got a low level of light touch afforded by the application of the tape. And then you've got the ability to manipulate those variables because the tape is elastic. So if you stretch the tape, straight away it starts to contract. And when it does that, it pulls on the skin and it further stimulates the skin's mechanoreceptors, which then heightens the stimulus and perhaps gives even more awareness of an area where the nervous system might be reduced or dulled, or sensitivity is reduced. So you're boosting sensitivity in areas where it's been reduced. And of course, when you have better sensory input, you have the ability to improve the motor output and motor control, and so on as well. Tape can also be used in areas, sorry, just to finish that point, if there's areas of high tone, because of course with neurological issues, you can have areas of high tone, then the tape can be used in different ways to try and reduce the muscle tone as well. And as I say, there's research where the tape's been used in specific neurological conditions and scenarios, and the types of professionals that are doing the training are using the tape. They're very evidence-based professionals. It's being done in the NHS, and that means it has to have not only an evidence base, but it has to be proven to be useful and a good spend of the limited resources for it to be credible.
Libby's just asked a question with regards to the accessibility for rock tape in the UK and in Ireland. Can you talk to her on that?
Yes, of course. The accessibility to training.
To buy it, or train?
Yeah, well, okay, we have the rocktape.co.uk website, which is where most professionals would buy their tape. And if you sign up as well on the website, you can get some professional discounts for buying the tape. There's rock tape offices in other countries too. So we have a reseller in Ireland.
She's in Dublin.
Yep,
quite
in Dublin.
Close to Canada's pub.
I went to Dublin and I can't recall that pub, but I did go to a very nice one. But we have rock tape is sold. There's a company in Dublin which sell rock tape, so that would be the place to get it.
We have it. I believe that rock tape has taken off because A, it started in America, and B, it went straight into the universities and taped footballers and swimmers and your athletes, and they have the people who can fund or any research and anything over there. Like it's just automatically, it's a steam train. So that's where I think that if it had been anywhere else, it may not have had this impetus that it has had, but it's really really gone to an area that we can afford to get research. And it's not saying that rock tape is the only stuff that doesn't work. It's just the one currently that we've got the most research on. Yeah, Diane. Okay, so Diane said she did a rock tape course late last year. I really enjoyed the benefits. We had a guy, Ron Alexander, who used to teach functional fascial taping with tape that wasn't. At that stage it wasn't elastic. It was your old BDF tape, or whatever they call it, and he could pin and then just take tiny little bits of skin and then tape and so it was just doing this creep. And the creep was he was doing a lot of stuff for ballerina, like for ballet, classical dance, made a huge difference.
Yeah, I'm aware of Ron Alexander, and I've looked at some of his work and techniques, and you're quite right. Very good
Great
technique.
Great for feet, and smart with feet. What we might do is we might jump over to a quick plug for the Q Academy, and then come on back to more about the taping, and then maybe some EP, some exercise physiology.
Yes, absolutely. It'd be good to talk about the exercise and how that could work. Fantastic.
Okay. Back in a moment.
My name is Jade Afu. I studied Cert 4 massage in 2014 and then went on to remedial in 2015. I was working in ASICs. I was retail, Lorna Jane. The real reason why I went and studied was my daughter was, she's been quite sick for about 7 years on and off. She's had a couple of chronic conditions. So I found it hard working in a job and having to leave because my children are sick, or I've got to go to hospital, or there's just so many things going on. For me, I needed another option. I've been set up for about 8 years now, working from home. Having a home business has been like such a blessing to my life. I don't think I could have done what I've done somewhere else just with my own circumstances. My life's very busy. I've got 3 kids. And this year has been a little bit different again because now I've got 3 kids playing sports every afternoon. So I do try, if I can, work in between school hours. I feel like you can make it work to your advantage. So you can either work as hard as you want and be stressed and all the things, or you can make it flexible.
They're the bomb. If you're interested in Australia, or even if you're in Southeast Asia, or even over here, because they do online courses and they are amazing. I used to teach for them, and Monday through Thursday we would teach, and then Friday we would learn the next curriculum and how to apply it in a neuro-linguistic programming, to like fun and brain breaks, and everyone, like you'd see a class come out and they were all drawn on like the full elementary system, or whatever. It was just a fun place.
That was a great advert, and I couldn't help notice the cupping marks on the client in that. I wondered if you wanted to talk at all about cupping, because that's certainly kept me busy as an educator for the last 4 or 5 years.
You talked about what was it, pod cups or something?
Yeah, so rock tape has the tape, and then we have the rock blades, which are metal massage tools, and then we have rock pods, and the pods are silicone cups, silicone decompression cups. So,
you slide?
Yes, there's different types. There's the rock pods, which are to fix on the skin and mobilize the soft tissue, or to wear whilst you're doing stretches. They're amazing. They're fantastic. If people have not tried them, I'd recommend it because it's such a unique feeling, and clients tend to really benefit from it and request it next time they come back. We have the RockPod glides, which of course, Paula, as you say, they glide, so that's what they're designed to do. And then we have the RockPod vibes, which are RockPods that vibrate with a high frequency vibration. And the best place to use those is over the back of the pelvis, lower back or pelvis, for any pain or discomfort around that area. They can work wonders for reducing pain.
The methodology around there is working on the mechanoreceptors and the
yes, it's just the vibration, really. The high frequency vibration is analgesic, so it immediately reduces pain and reduces the sensation of stiffness, which then allows you to move and mobilize with a lot more comfort, and then that can lead to longer term positive outcomes, because you're engaging in movement that you were previously avoiding. So they're my favorite product.
Okay, so I'm going to go back to the young Daniel Lawrence, who wrote his first book on lower limb tendinopathies. How would you apply what you know now? Pick a tendinopathy, whether you're going to just pick one of the ones from the hips down.
Yeah.
And talk me through how you would, with the tools the tools that you have, how would you design a treatment program?
Yes, of course. Well, I might choose the most common tendinopathy. I used to think was Achilles, but actually, according to the research, it's gluteal tendinopathy, which is sometimes called trochanteric bursitis. To a patient, it would be hip pain or hurts here, but it's often confused with hip arthritis, or people compound it with potential hip arthritis, and of course that makes them a lot more fearful and a lot more worried about their prognosis and their outcome. So gluteal tendinopathies, lateral hip pain, it's usually quite easy to get on top of, and the patient, however, is usually quite worried, anxious, and somewhat disabled by it. So there's very quick ways that you can identify what the issue is. The first thing is to move the hip in a testing procedure to see whether the hip is mobile and identify where the pain is. So if the hip is mobile and still has a good range of motion, particularly up into flexion and some internal rotation, then it's most likely that it's not an arthritic hip.
So that's passive.
Yes, passive or active, but passive. The location of the pain, if they're getting the pain in the groin, it indicates it might be more jointy. But if the pain is on the lateral side, once again, it's very unlikely that that's osteoarthritic related pain. It's going to be the tendon. There's usually some things that they're doing which are aggravating the tendon, and they can be very subtle things, but not only are these important from experience, but they are specifically mentioned in the research as well. And one of them is standing and hanging on the hip, which is where you stand and take the weight through one leg, particularly mothers holding a child on one hip and taking all the weight on that leg. It bows the hip and it puts passive strain down through the ITB, and that in itself causes compression against the lateral hip and can irritate the tendon. So that's one thing. And often with these things, the pain is not directly linked to the activity. So the pain might be more less specific and quite diffuse and quite sort of random, but the activity is potentially aggravating it or even causing it. The other one's lying on their side at night, which can often be painful. And simply putting a pillow between the knees can make a huge difference. And not everything needs to be complicated with what we do. Sometimes the simplest intervention in the right place at the right time can make a huge difference. So stopping the aggravating factors is a key thing. And the exercise for tendinopathies, I'm a firm believer in isometrics for tendinopathies, for all tendinopathies, from the shoulder to the Achilles to the hip, the gluteal one we're talking about now. So all they need to do is lie on their back, knees up in kind of a Pilates pelvic tilt type position.
Ooh. One of us is frozen.
Rigid strap of some sort, and push their knees apart. I hope I'm still with you. Push their knees apart against the rigid strap. So it's a forced abduction, but it's stiff because you're pushing against a resistance. And to hold that for a duration of time, say 30 seconds, do that a few times. And yeah, that removing the aggravating factors, adding in that simple exercise usually makes a big difference within a couple of weeks.
Do you find that they're more female than male with that lateral gluteal?
Yes.
Like
yes, absolutely.
95% would be female that I see versus.
Yes. The research shows there's definitely a heavier weighting for it being more common for females, and I think that's probably a biomechanics thing. But yeah, of course, I still see it in males as well. But yeah,
I was watching there was a massage magazine or one of those JBMs, one of the courses, online information magazines, podcasts, and talking about the women that cross, like we histrionically cross legs much more than men do. Like it's just us. We don't mansplain. Well, most of us don't. And I spent my whole time with cross legs, so I know it's like, oh, stop doing that. But talked about what happens at the hip joint when you've got the piriformis that's continuously lengthened and the psoas group that's continuously shortened, just sitting in these fixed, your antagonist and agonist are doing. You're actually putting them into a constant mix match of what they should be doing, and again applying isometric, like getting them to be in supine with the knee bent and dropped out, and just get them to, like, you put your palpation, hand underneath the buttocks, hand on top of that where you're actually feeling for the TFL, really piriformis TFL area, and getting them to do a external rotation isometrically and then an internal rotation isometrically, and get them to try to feel the connection at a deeper, like a much deeper level. And it really is talking to your patient about an awareness. And I remember doing a video for one of my courses, and I didn't prequel that to Bianca. I just said, okay, this is what I want you to do. What's your feedback? And it was almost like she'd watched that video. The words that came out of her mouth were, it just feels like there's much more connection. I didn't really understand. Like, it just feels like it's going all the way through, and I'm getting a picture of what my hip's supposed to feel like. I was like, wow, okay. It must work. But I find that doing other component muscles, like for me, I go, right, there's a tendinopathy. What else can we deload? Are the short adductors so short because of standing in that hip position that we could maybe do some myofascial gliding or cupping or whatever on the short adductors?
Yes, okay. So a couple of other aggravating positions to avoid, because I mentioned the side lying and hanging on the hip. One you mentioned already, which was the cross leg position to be avoided with gluteal tendinopathy, and the other one is low chairs to be avoided as well. So those are key things. In terms of soft tissue work and massage, I found that getting into the glutes is one of the first areas that you can do some good work and reduce muscle tone and sensitivity. So getting into the glutes using either your hands, elbows, cups are great for getting deep into the tissue because you can decompress instead of compressing. And even using some mechanical tools like massage guns. I'm not a huge fan of massage guns pulverizing people all over the place, but the glutes and the feet, in fact, are kind of, I find, very responsive to the use of a massage gun. possibly for respiratory too, for loosening secretions, but that's beyond musculoskeletal. But interesting use of those, for using them for the VIBs. So yeah, that's a bit about the gluteal tendinopathy, and you can absolutely do hands-on. And in my book, there's a chapter on massage for the tendinopathies, because the patients, the clients, respond really well to massage to help manage tendinopathies. It's not curative, of course. The curative element comes from loading and load management, but you can certainly get some quick wins and symptom reduction from doing some hands-on work around tendinopathies, and that can be very beneficial.
It's great to read that. I hear that. And I'm looking at Diane again, has said that she did the course, the rock tape therapy tools for soft tissue, that course, using blades and rock pods, etc. So, well, it's coming across to Australia. So, Libby, you'll find it over there in the UK, definitely. I look at the time and go, oh my God, we're looking over 5 minutes left. The time goes so fast. But I want to know two things, because I'm busting to ask how I've got a YouTube channel. I've got hundreds of videos, and every time a patient finishes in my clinic, I will then do a small video. Hey, Daniel, it was great to see you today. Just recovering. Remember what we're going to do. We have to stimulate, showing the exercises on Vimeo, shoot it across to them. And then I've got that in the patient Vimeo file. But I have got YouTube for loads and loads of other things. Was it a big stumble? Was it, are therapists too scared to put stuff on YouTube? Have you got 3 take-homes? Don't be terrified, because this is the easy bit to do, or that's like, sell YouTube, baby.
Okay, so the first thing is the barrier to entry. Well, there is no barrier. It's never been easier to start a YouTube channel. It used to be the case that you had to, learn how to use an expensive camera or something like that. But now phones are no longer phones. They're pretty much high-tech cameras ready to go, and they take care of most things for you. So one of my colleagues over here in the UK has a wonderful YouTube channel, Pressure Point Massage Training. Claire Riddell, I was with Claire just last week, and we made a YouTube video together, which is on the latest one on my channel at the moment, and it's on Claire's too. Anyway, Claire uses an iPhone and has done for some time, and her channel's popping really well and building, and it's fantastic to see. But she just uses her iPhone. But it's like, oh, I just use an iPhone. Those things are really expensive these days, and they are very high tech. So you've probably got the equipment already ready to go, and the next thing is you would be worried, like talking to an audience, public speaking, talking on camera. I understand completely, and I still don't feel that comfortable doing it quite often. But the key thing is you are in a profession where you help people. You want to help people, and therefore that should be your focus with the video, is simply make a video that can help somebody, package something that can help somebody. You might simply show some massage techniques, and if you do that, you can make a faceless YouTube video. You don't need to show your face. You don't even need to talk. You can just demonstrate some massage techniques, and then work with that content, and that can create a video which helps somebody because they want to do the techniques for their friend, or they're doing a massage course and they can look at the techniques. So you can do that. And I've seen channels where nobody appears on the channel. It's just hands and the massage techniques, and it works really well. Also, again, the key focus is on making something that can help somebody. So rather than, I'm not a big fan of posting stuff on social media and oversharing. I think that's the younger generation generally seem more comfortable with that. But for me, I just want to make a video that will help somebody from a physiotherapy perspective, and that's the key thing. So yeah, that's it really. You're ready to go. Make a video that can help somebody. And the third thing, you said 3 things.
Lighting.
No, like, not that that's not important, but I wouldn't prioritize it in the top three. It's difficult, Paula, top three here. I would say planning. Don't just put the camera on and then start waffling away. That'll be an uncomfortable experience for you and for the viewer. I would say plan. It's okay to literally plan what you want to say, what you want to show, and plan how you're going to film it. You know, is the camera, you know, close up, or is it further back? So if you plan what you're going to do, then all you need to do when you go to film is follow your plan. If you're nervous,
we got a quick loss of Dan for a moment. I'm also going to point in there that we can have, if you think about what you love watching, how much do we love watching bloopers? How much do we love watching the outtakes at the end of the Marvel movies or whatever? Like we love watching people cock up and do stupid things and laugh and all that. So don't be afraid if you do a 7-minute video on stretching the piriformis and blah 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 or whatever you pick, and you run through it and you make some mistakes. You can look. They're so easy to edit that stuff out. Like the YouTube editor is like ding ding ding. Keep those and keep them as your Christmas special for just your patients. So that because it's hilarious. It's great fun.
Yeah, absolutely. So that's my three. I hope they came across okay.
They did. I'm sorry that we lost you for a moment. Now, how can people learn and get to you? They go through not through the YouTube channel. They can learn stuff from your YouTube channel, but how do they come and do your courses or get your books or online teaching?
Yes, of course. So the books are on Amazon. I have an author page, Daniel Lawrence, on Amazon to find the books: Lower Limb Tendinopathy, Clinical Cupping, and Exercise for Pain Relief. And the education is through rocktape.co.uk. We have education in Australia for Rocktape too, with an Australian team, and in other countries around the world as well. So worth looking up whichever country the listeners are in. And then for the YouTube, which is the Physio channel, and then there's some links through there for some other online courses. And I do offer some mentorship for people that want to learn how to create videos and how to start and manage a YouTube channel. That's called the Health Creator Pro program. That's me.
That's excellent. That's excellent. Well, two of the people that are here chatting away are on my mentorship, massage mastery mentorship program. So it's that. I think that's a lot of educators. Where we go now is how do we pass our skill sets on, because we suddenly, like, I've been in this industry for 30 years now. Not that I look that old, but there you go. We're after the hour. It's been an absolute pleasure. The time always flies. I don't know about you, Dan, but it's like, oh God, oh my, like I looked up at the clock, went, well, that's 37 minutes. Where did that time go? Some great nuggets. Please, if you're interested in getting any information on assisting your patients, even talking about our inhibiting the nervous system, that in itself, you can get loads of information from Daniel's website on how to do treatments that will help you, help your clients and patients in that space. But I'm not sure who we've got next month. Might even have a chat to see about what Claire Riddell's doing. Or was that her name? Claire?
Claire Riddell, runs a massage school in Nottingham, and has been involved with education for many years, decades, and she runs a successful massage YouTube channel as well. Okay, we'll either be there or we'll be crossing over to the other part of the Northern Hemisphere and getting a couple of Yanks in for a while, or Canadians, so that we can share the time zones. But
Thanks everybody for showing up. Keep your eyes on the Your Musculoskeletal page, the free Facebook page, because that's where we'll find out where the next one is, or in our massage mentorship group, guys. And Daniel, thank you so much. It's been an absolute pleasure, and stay safe. See you later, everybody. I think he's lost again, lost in translation again. Have fun, be safe. Love you all. My little heart. Oh, back? Yes.
Thank you very much, everybody.
See you, everyone. Bye.
Thank you, guys. Thanks for joining us. Goodbye.